Okay, so hi, I'm Grace. I'm a first year resident, and we're going to be going through some of the neuro pharm with these two of my students. And I'm a big sketchy person, but I know that doesn't work for everybody. So I kind of wanted to make some videos on going through some of this content and how to kind of consolidate it. So, Janelle,
Okay, I'm Janelle, and I don't know what specialty I want to go into yet. So
totally
we'll just
fine.
find out during rotation. Yeah.
Arena.
Good morning. I'm Amina. Not sure yet which specialty I want to do. I have a few in my mind, but I will see.
Okay, so I'm going to share my screen, and the first thing we're going to do is go through the first aid. Um, Not because it's necessarily the best way to learn the farm, but because I feel like it is just a good consolidation piece for it. Um, so the first thing that we have here is the anticonvulsants. The hard thing about the anticonvulsants is there's a lot of them, um, and there's not too much to know about each one, so you just have to know like the one thing about 15 different drugs. Um, the nice thing is that you don't have to know that much about each one. So there's a lot of them, but you have to kind of be able to group them in your brain. And a lot of them have a lot of very common mechanisms of action and side effects. So we kind of want to be able to group things together and remember the exceptions. Okay, so we'll start with you guys can see my screen, right? Yeah, you can. Okay. The narrow spectrum focal seizure medications. So, Janelle, take me through what we would need a narrow spectrum anticonvulsant for.
Um. Well, if it's a focal seizure,
Sure. So, what would a focal seizure look like on a question stem?
so it could either be a patient with they either have a loss of consciousness, which would be like the partial. No. So they would have either a loss of consciousness or they could have consciousness. There's the two types that we have.
Okay.
Um, and then uh, you would also probably see they would say that the person could have I don't know for sure, but
Okay, no, that's
I
perfect.
do yeah.
So the big thing is that they're not going to be kind of in that television seizure. You're not going to see someone shaking in the bed or on the floor, right? They're going to say that their hand is shaking, that their finger is shaking, that they're smelling something burnt, and then, their legs start shaking, something focal, something not full body. Okay. The broad spectrum or the generalized seizures is going to be that full body kind of situation, right? So it's usually weird side effects. But that being said, most of um, the drugs are used for both in real life. So, okay, so mechanism of action of these three are either blocking sodium channels or blocking calcium channels. Okay, mostly that just runs neurotransmitters, right? If we look at our, I don't know if it has sodium and, yeah, here they are. So on the postsynaptic neuron, we have sodium channels and calcium channels to activate depolarization. So if you block either of these, you're going to have less depolarization and less signal sent. So we're basically just trying to tell the nerves, hey, you're sending too many signals, send less, right? And so if you look through all of these, block sodium, blocks calcium, block sodium. Almost all of these block sodium or block calcium. So if you have a question on a seizure drug, those are the only answers you should ever put down. Okay, I don't want you to memorize which ones are calcium and which ones are sodium because it's just kind of a waste. It's half and half. You have a 50-50 shot. It's silly. Okay? And they don't usually ask the mechanism because it doesn't really matter. Right? They're all kind of the same. There's some exceptions. Okay, so the big thing with this is the side effects. So, phenytoin. What are the side effects for that? The common side effects for that, Amina, you want to read these? I think you're muted. Amina, are you here? No, you don't want to? Okay, Janelle, go for it.
So, sedation, dizziness, diplopia, gingival hypertrophy, rash, hirsutism, drug interactions, the CYP 450 induction.
Okay, so sedation for any neuro drug is kind of like nausea and vomiting for any GI med. You're not going to memorize it. Every single neuro drug is going to cause it, right? If I look here, I see sedation, 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 sedation. I'm also seeing dizziness listed for all of them, okay? So what that means is they're not going to ask it, and it's not something you're going to memorize for each one. It's something that you're going to say, okay, in my list of what do seizure drugs do, so at the top of your book here, you're going to type all cause sedation, dizziness. Okay. Um, then we see gingival hypertrophy. Does anybody know what that is? Have you guys seen pictures of that?
Yeah, the gums like are kind of just bigger,
Yeah. There's only, I believe,
small.
two medications that really cause that. Do you know what the other one is? Either of you? This is the picture I like to give. Like they're literally growing too much. Hypertrophy. So the other one is verapamil. Um, for whatever reason, obviously, that is a calcium channel blocker, different types of calcium channels, so you can even say it's the same. But they both work into possibly doing gingival hypertrophy. So that calcium channel blocker is a little bit more common used of a drug than phenytoin. Um, and honestly, because phenytoin has so many serious, rare side effects, they're going to ask you that instead of the gingival hypertrophy. So if you see gingival hypertrophy, it's probably verapamil, the calcium channel blocker. Also hirsutism, right? That's not something that we see too common with drugs in general. Um, we do see it with a few different ones. Um, Ones I can think of off the top of my head. I'm not sure any. Can you think of any? Pretty sure one of the like tacrolimuses can do it, sirolimus or tacrolimus. And of course, anything that, blocks estrogen can cause some virilization. Okay. So the only one we're really going to memorize from this one is gingival hypertrophy. So that's the one you want to highlight, and you want to write um, verapamil next to it. Everything else is going to be in general. Okay. Rare but serious side effects. What's SJS?
Steven Johnson syndrome.
Yeah, so really, really serious skin condition where all your skin falls off. Okay, that's real bad, real bad. So, that's something we're always looking for. Technically, it's kind of like an autoimmune process, Stevens-Johnson syndrome, and a lot of different drugs can cause it. It's usually antibiotics and neuro medications, but there a lot of things can cause it because it's your body just reacting poorly to it. And if you have certain mutations or phenotypes of your genes, you're more likely to get it. Stress syndrome, they don't ask about too much. It's this eosinophilic thing where you get some rashes. It's also common with vancomycin, which also has red man syndrome, so not a big deal. Osteoporosis and folate depletion. This is something they will ask. Um, do you know people who are on phenytoin, are they usually on it for a short time or a long time?
Well, it's narrow spectrum, so would it be like a long? Well, that probably doesn't. Does that have anything to do with the
It
fact that it's
doesn't.
narrow?
So think about seizure medicine. Is seizure medicine usually a chronic condition or an acute
Chronic.
condition? Chronic, right? So of course there are things where people can have acute seizures, right? Sodium abnormalities, brain bleeds, yeah, really severe infections, etc. But most of the time somebody has epilepsy. Okay. Now, if someone to actually look at the numbers, It's not that uncommon for kids to have like a seizure once in their life. But as far as like STEM questions go, or what you're going to see your patients with, they're going to be on phenytoin for 10 years, right? So the chronic things that happen, like folate depletion, are actually really important because once you give it to them for a year or 6 months, you don't care about SJS or DRESS syndrome. Those are things that happen very acutely. That happens when someone comes in a grand mal seizure and you have to give them phenytoin to prevent re-seizures. But osteoporosis and folate depletion is something forever they're going to have to be on folate. Okay. The other big reason folate depletion matters is because when you don't have folate and you're a woman, what happens?
Can it affect pregnancy?
It can affect pregnancy. You
Uh,
have neural tube defects, right? And phenytoin has a whole slew of birth defects that we'll look at when we finish this page. So much so that it's actually called phenytoin or phentoin, I don't know how to pronounce it, syndrome. And so knowing that it has to do with folate makes sense because it causes all of these birth defects. Okay. Then we have carbamazepine, not how you say it, but I think it's funny to say it that way. Um, Sedation, dizziness, diplopia, same things, right? So these things that I see in common, I'm going to highlight in pink. These are things that I am not going to memorize because they're common with all of them. Okay. Vomiting and diarrhea, I will never care about a drug ever. Every other drug calls about. Okay. SIADH. Okay. That's something that only certain drugs cause. Okay. So that's something I want to pay attention to. There's some SSRIs that cause it. I mean, honestly, there's a lot of different drugs that cause it. But I want to know that this one can cause that. So what would I be worried about if I saw a patient who had a drug that causes SIADH? What in the question stem would make me worried that they have SIADH?
um, they could probably have you probably in their like serum studies they would have hyponatremia.
Yeah,
Uh,
hyponatremia and all the symptoms of it. They're probably also peeing less, right? So hyponatremia and hyponatremia can also cause seizures, right? So not something that you really want. It's not, it's something that we can treat. Do you know what the first line treatment for SIADH is? I get it wrong every time. It's not a medication, it's water restriction. So every time I'm like, okay, let me think about my, SIADH blockers. Let me think about my ADH blockers. Not the answer. It's always just give a fluid restriction. They have too much fluid, you just restrict their fluid. That's first line. Okay. Other things we have DRESS, SJS, hepatotoxicity, same things that we saw with the other drug. So we don't care. I mean, we care, but because they're serious, but we don't care because they're not special, if that makes sense. Agranulocytosis, aplastic anemia. What is agranulocytosis? That's when we have no granulocytes, no neutrophils. Okay. And neutrophils, are they important for acute infections or for chronic infections?
acute.
Acute, right? So what that means is the moment somebody who gets sick, like the littlest bit of a tickle, they can get very, very seriously ill because they have no acute immune system to fight it off. Okay. And once again, we see folate deficiency and teratogenicity. Okay. So the big things I want to remember with these is that it can cause really, really serious side effects, folate depletion for both, agranulocytosis, these Stevens-Johnson syndromes. Okay. Last one, I've never heard this word, gabapentinoids. Very important thing. They will ask this over and over again. This was asked on my ABSite this year. Do gabapentin and pregabalin work on GABA?
No.
No, they block calcium channels, okay? They were named a long time ago when we thought they worked on GABA. They don't, okay? The reason we thought they worked on GABA is because this is what they do. They just make you sleepy. They won't ask you anything about gabapentin besides the fact that it blocks calcium channels. They very specifically ask you the mechanism of that one because it's the opposite of the name. Okay. You may have heard pregabalin called Lyrica. Some people are on that. This is usually for neuropathic pain. Okay, your patients are not usually on this for seizures. Your patients are usually on this for nerve pain. So they have sciatica or something like that. Okay, so it's not something you're going to choose for somebody who's in a seizure. Okay. Ethosuximide is a really, really easy one. What does it treat?
Absence seizures.
Absent seizures. The only thing you need to know about it is they're going to talk about a kid who has ADHD, but now his teachers are noticing, even on his ADHD medicine, he just stares out the window for 5 minutes. And then they see those specific spike waves and whatever, and they start talking about this very specific EEG finding. And the answer is going to be ethosuximide. Okay, great. All right, so now we have our broad spectrums. Okay, so these are for um, not only are they for focal and generalized seizures, so you can give them for both. So a lot of times the question will be like, oh, this patient sometimes has focal and sometimes has generalized. What should you give them? And you can give them valproate, you can give them levetiracetam. Those are the main ones. But because these are broad spectrum, they're also often used for other things. Like people are on topiramate for migraines. Levetiracetam we use as a sedative, and stuff like that. Okay. So, valproate, again, we do not care about the mechanism. This one also works on some GABA transaminases, which I think prevents the breakdown of GABA, but we don't really care, right? All of these are the same. Okay. The only one we care about is this one because it's different. This is also new. Depending on what copy of First Aid you have, check and see if yours has that.
Yes, mine has it.
Yours has it. So my 2017 version definitely didn't have that. Okay, so that's a semi-new thing. That doesn't mean they're more likely to ask about it. It takes USMLE a few years to catch up. So it just is a thing. We discovered what it worked. Before it used to say mechanism unknown or potentially sodium channel. We don't know. Okay, so once again, we see our commons, sedation, dizziness, vomiting. Don't care. Okay, sedation, dizziness. I'm gonna cross those out for all of these. The fatigue doesn't seem like the fatigue I'm gonna leave because we use it as a sedative, so it's like really severe. I remember when I was in the OR, I'd be like, "Can you please just give them some Keppra? They're like going wild when they're waking up," and that's what levetiracetam is. It's Keppra, and it helps in a sedative in an acute environment. Okay, so valproate. What are the side effects that are special? Weight gain, hair loss, easy bruising. Okay. I don't really care about hair loss. Your patient might care about it. Easy bruising, weight gain. I really haven't seen a lot of questions about that, to be honest. Most of the time, valproate, they're asking somebody who has either juvenile epilepsy, which is a very specific type of epilepsy, or where they have focal and generalized. So it'll be like this 14-year-old kid comes in and sometimes he has focal seizures and sometimes they spread to generalized and sometimes they're both and sometimes they're one or the other. What should you give them? Valproate. It's good for both. Okay. The big thing we worry about is this one. This is the one they will ask you about, the hepatotoxicity, the pancreatitis. You should assume that all of these are teratogens. Technically, not all of them are, but they're all pretty serious drugs. They're not. All of these have a whole section for serious side effects. That means they're not gentle drugs, right? Is there any other chapter in the book where you have it separated by common versus serious side effects? No. Okay, so the thing you need to know about valproate is that it treats both and it causes hepatotoxicity. So sometimes they'll say, someone is started on valproate. What labs should we get? And it's going to be
A
liver
little.
function. Exactly. Okay. Lamotrigine also can cause Stevens-Johnson syndrome and Jess syndrome. You're noticing that these things usually go together. It also has a rash. So the spectrum, it can be a rash, it can be a full-blown Stevens-Johnson symptom. Levetiracetam, Keppra, can cause neuropsychiatric, aka psychosis. Okay. And then topiramate, you will see this more for migraines. Okay. This is sometimes called the supermodel drug. Have you heard that before?
No.
Okay, so the main reason is for this side effect here. And it's an inappropriate mnemonic, but we'll go over it because it is helpful for memory. So it causes depression, it causes a slowed cognition, so it makes you dumb, skinny, sad is kind of the idea. So they call it the supermodel drug. There's not a lot of drugs that cause significant weight loss. This one does. People tend to lose a lot of weight on this drug. And so in the past, some people have abused it for weight loss, like supermodels. Um, but so that's really what they're going to ask you about is someone's on this migraine medicine, um, and they're super skinny. What should you do? Right. Um, and then it can also cause kidney stones and glaucoma. So you should know the kidney stones as well. I don't know how that fits into the supermodels, but you just got to imagine all the supermodels have kidney stones because they're not drinking enough water. Okay, so to recap, our narrow spectrums are phenytoin, carbamazepine, and I hesitate to even put the gabapentins on there because they're really just for pain control. Okay? Everything causes sedation and dizziness and diplopia, plus or minus some nausea and fatigue. Really serious side effects are Stevens-Johnson syndrome, stress syndrome, hepatotoxicity. Okay? Special things is we have gingival hyperplasia for phenytoin, SI-ADH for carbamazepine, and then our supermodel symptoms for topiramate. Are we on board with all of that?
Yes.
Okay. All right. So now we're going to start looking at the anticonvulsants picture. Okay. So we have our presynaptic. Okay. And you can see there's sodium channels here, there's calcium channels here. We looked at the ones that were postsynaptic. So and now I'm looking at this picture, it's actually saying that these drugs work on the presynaptic ones, not the postsynaptic ones. Okay, so everything works up there. The only thing that works down here is this GABA, and that's working over here. So not even an issue. So presynaptic. So if you have to choose something, sometimes they might have pre and postsynaptic sodium channel or pre and postsynaptic calcium channels. If you're dealing with these, you're going to go with pre. Okay. So we have a ton on both. If you do want to break it up, it's ethosuximide and valproic acid that are listed as just calcium. Okay, and this is preventing the action potential from depolarizing and releasing glutamate. Is glutamate inhibitory or excitatory?
Excitatory.
Exactly, so we want to block that. And these SV2A receptors that levetiracetam blocks is just allowing these vesicles to actually be released. Notice that's what the calcium does too. The calcium in all neurotransmitters, we usually talk about the calcium being the final release, whereas the sodium is the propagation of those action potentials. Okay, so does that make sense? So everything is blocking glutamate. Everything, all of the anticonvulsants are blocking glutamate, but they're all doing it in different ways. They're reminding us that glutamate binds to which receptors?
Sodium and calcium.
Yes, but specifically the NMDA receptor. Okay. And also apparently this AMPA receptor, which I can't say I've ever seen before. Maybe you've seen it before. I haven't. But we'll highlight it so it's a word. And then they have benzos, phenobarbital, and topiramate is working on GABA. GABA is excitatory or inhibitory?
Inhibitory.
Inhibitory. We love GABA. Okay. So now we'll go to the actual seizure meds that you're going to use for an acute situation. So episode 1 of Grey's Anatomy. okay? Meredith has, on her first day, a girl who goes into a seizure and she has to run it because she's paging neuro, and he's not getting there fast enough. Okay, and they say, "What do we do, doctor?" And she says, "I don't know." And they say, "What do we do, doctor?" And she says, "I don't know." And then she says, uh, "Give lorazepam," or I think she chooses lorazepam. She gives a benzo. Okay, so go back and watch that episode. Very important, because when we have an acute seizure, the thing that we're putting down somebody's IV is Ativan. It's benzodiazepines. Okay. We can also use barbiturates, but they're more dangerous and they've just kind of lost favor over the years. You want to think of benzos and barbs as basically the same drug, but one is safer than the other. So anytime you can use a benzo for something, you can also use a barbiturate for it. Maybe we use them both for alcohol withdrawal. We use them both for seizures. Um, but we rarely use barbiturates because they're dangerous. Does that make sense?
Yes.
Okay, so phenobarbital or pentobarbital, never seen pentobarbital, but you can guess from the name, they're barbs. Okay, my mom's name is Barb, so I have a special close, feeling for barbs in my head. Okay, so mechanism, GABA. Okay, you might not remember that barbiturates work on GABA, but you're gonna remember that benzos work on GABA. Okay, now, what is the most common drug of abuse that affects GABA? What's something that I had a glass of last night that stimulates GABA?
Alcohol.
Alcohol, okay? Barbs and benzos are stronger versions of pill form alcohol, okay? That's why we can use them for alcohol withdrawal. That's why a lot of their side effects will be the same as alcohol, okay? So when we look at that, we want to kind of consider that. So it facilitates GABA, so alcohol, by increasing the duration. This is rarely asked, but they do make a big deal about it. This is a higher level question. Specifically, barbiturates work on the duration of keeping the GABA chloride channel open. Okay. So I think of my mom, Barb. She just always keeps the door open, right? Her house is an open door policy. She's a lovely lady. She keeps the door open 24/7. Anyone is welcome. It's an open door policy. Okay. So I think of her front door with a big calcium sign on it, or not calcium, chloride sign saying open all the time. Okay. Um, they mentioned that barbiturates for duration. That doesn't work for me, but whatever. So clinical use, anxiety, seizures, insomnia. Okay, you use alcohol to help you sleep. You shouldn't, but it does. You use it for anxiety and you use it for seizures. Okay, now this sentence right here is why we rarely use these unless we absolutely have to. So, what is the big side effect with this?
Respiratory and cardiac depression.
Which can be fatal, right? So, if you stop someone from breathing, that is bad. What is the other drug um, that is commonly used in the hospital and on the streets that causes severe respiratory depression? Sometimes it's injected IV, people have track marks,
Like opioids.
opioids, right? So, if I get a call in the middle of the night, hey, the patient's respiratory rate is 6, my first thought is give them Narcan, right? When I see somebody who has a low respiratory rate on a question, on USMLE, it's opioids 100% of the time. Okay, you need to give Narcan. And I do give patients Narcan in real life in the hospital. Of course, on the streets, that is often what causes people to die, is the respiratory depression. We don't give barbs much in real life, so my first thought is not, oh, they're on barbiturate overdose. But if I am giving barbiturates for some reason, um, I need to really pay attention to the respiratory rate. Okay. It's a CNS depressant. It's alcohol, so that's not super surprising. And it can be exacerbated by alcohol. Why is that? Because they both work on GABA. Okay. You get dependent on it, just like alcohol. There's drug interactions. And here's the big thing too. Not only is it dangerous, but do we have a Narcan for it?
No.
No, we have no reversal agent for it. Okay, so if somebody overdoses on this, we might just have to intubate them and support them or give them vasopressors, right? You have to keep them alive artificially. You can't just reverse them. Okay. And then a big thing here is that it's contraindicated in porphyria. Why is that? Is because it's a big stimulant for porphyria. This used to be on questions more. No one cares anymore because we don't give barbiturates. So very rarely mentioned. Um, the big things you'll see for porphyria are usually like starvation, or they haven't been sleeping well, or they're ill, and that causes their trigger.